of the engagement of residents, and we're trying to, in big projects like this, always to have resident involvement. So thank you again for joining, and for Dr. Alia also involvement and leadership. تفضل يا دكتور عمر.
السلام عليكم. شكرا دكتور ياسين. I'm not sure if you can see my screen. Can you?
Not yet. I don't see your screen.
Okay. Share screen. Now?
Yes, but if you can put it on the view mode, would be better. Yes, perfect.
Is it?
Yep.
Okay. Okay. Assalamu alaikum. This is Dr. Amro. I'll be talking about the background of juvenile study. First, I'm going to go back in the history. You know that oxygen was discovered in 1774, and the first mechanical ventilation provided negative pressure ventilation was in 1928. That was in the polio period. Then in 1952, the first clinical use of positive pressure ventilation occurred at that time. And since that time, the evolution of mechanical ventilation started. And we know that mechanical ventilation is widely used in patient admitted to ICU. It's cornerstone feature of critical illness. So many clinical physicians at that time took initiative, and they said, okay, so mechanical ventilation is an important machine that we use in daily basis in ICU, but we need to know the clinical outcome of this machine, and we have to understand the mechanical ventilation in more deep understanding. So from 1998 until 2016, they published 4 articles of 4 observational studies, and they found a significant decline in mortality. So in 1998, the mortality was 34%, and in 2016 was only 27%. So the aim of this organization was to analyze the evolution of mechanical ventilation over time, and also study the different practices of using mechanical ventilation and the effect of it on mortality over time. So this will give an update on usual care, and also give us a clinical outcome of using mechanical ventilation in real world. And for the first time, significant reduction in ICU mortality, as mentioned before, was seen in mechanical ventilated patients. And as we said, since 1952, the evolution of mechanical ventilation started. And we saw that ECMO, we saw that high flow nasal cannula, high frequency assisted ventilation, APRV, many practices have emerged at that time. This has improved our knowledge and also outcome in this field. But on the other hand, there was non-clinical aspect of it that we didn't pay attention to, and it was uncertain. It gives us great burden on health services. This challenge needs to be addressed, the non-clinical aspect of this all evolution of mechanical ventilation. Then COVID-19 came in 2019, millions of people affected, many deaths around the world, and also the practice of using mechanical ventilation have been different, or new practices have emerged, and many other have disappeared, particularly in using mechanical ventilation. So in this time, so clinical research needed to be conducted to give us a better understanding of the disease, like COVID-19 or other diseases, and also to develop better diagnosis and treatment. On the other hand, also we have to study the economical effect of these practices and of these practices to reduce the economical cost and enhance quality of health. So Gemini study 2022 will give us an analysis of the global burden of mechanical ventilation around the world. It also will give us comparable estimates of cause-specific to start mechanical ventilation for ICU worldwide. The result will include 57 countries, the result of 57 countries. It also will provide opportunity to gather newly available data sets and give us standard clinical practice and serve as global public clinical tool. So the main hypothesis of this Gemini study is to study the clinical practice of mechanical ventilation during the period of COVID-19 and see the influence of this practice on clinical outcome of these patients. The second one, there is worldwide variability in clinical practice of mechanical ventilation associated with an unidentified clinical phenotype that also is associated with mortality. Secondary hypothesis, we know that many practices have emerged during the COVID-19. But the thing is, these practices have been generalized on the people who don't have COVID-19, which also modified the clinical outcome of these patients. So the objective is to study these practices after COVID-19 and see the clinical outcome of it. The second thing, to study prospectively unsupervised clinical phenotype that allow to improve precision medicine. In the secondary outcome, to compare the data we had from the 4 observational studies to the result that we will have in Gemini study. And also to study the association between the differences of clinical practices of all mechanical ventilated patients after COVID-19 and see the clinical outcome. So what Gemini study wants to tell us is we must act globally to reduce the burden of clinical illness. Thank you. That was my presentation.
Thank you, Dr. Amr, for this excellent background. Clearly, the outcome of mechanical ventilation has changed over the last few years, as you explained. It was clear during COVID, even within 2 years, we see how the outcome of patients with respiratory failure has improved. So it will be a fantastic opportunity to look at the practices of mechanical ventilation support in Saudi Arabia. I see raised hand. You have a question, Ms. Lema? Okay. If not, I think we're going to move on to the next step, which is discussing the data. So, Ms. Iman will start, or Amjad?
Amjad first, because she will talk about the
Amjad Ghamdi going to talk about inclusion, exclusion criteria and other aspects of data collection. And what we have started, we already started in our hospital. So she's going to reflect on our experience in the last few days collecting data. Tfadali, Amjad. Rose, if you can make her a host.
Hi, Dr. Yassin. Hi, everyone. Can you hear me?
Yes. Hi, hello. Good evening.
Good evening. I will share my screen. Can you see?
Not yet.
Disabled participant screen sharing.
Rose, can you make her co-host?
Who, doctor? Who, doc?
Amjad.
Aljad.
Amjad.
Okay.
Okay.
Okay,
now
Prof.
okay, you should be able to share now.
Can you see it now?
Put it on the view view zone. Yes, thank you.
Okay, I'm Amjad, the research coordinator. I will describe inclusion and exclusion criteria for ICUs and study population. Starting with inclusion criteria for ICUs, each participating ICU should have at least 6 beds and or average of more than 30% of the patients admitted requiring mechanical ventilation. Also, the ICU to be eligible should have a specialist in intensive care medicine or visiting physicians with intensive care training and or physicians who have more than 5 years of intensive care experience. So this is inclusion criteria for ICUs. For the patient, we only include adult patient 18 years old or above and require mechanical ventilation endotracheal tube or tracheostomy. And the patient should be on invasive ventilation longer than 12 hours. In addition, we include non-invasive respiratory support, patient on non-invasive respiratory support, high flow oxygen nasal cannula, or non-invasive ventilation by BAB or CPAP for more than 1 hour. Also, we include adult patients in whom mechanical ventilation will be started outside the study ICU at the same institution and or a different institution, including emergency room and operating room, and were then transferred to the ICU at the participating center. So moving to exclusion criteria for ICU, we don't include pediatric ICU and post-operator anesthesia recovery room. So these 2 units will not be included in the study. And for exclusion criteria for the patient, as I said, we only include patients 18 years old or above. So less than 18 years old will not be included. Also, we don't include patients admitted after elective surgery and who require mechanical ventilation for less than 12 hours. To include patient, we should have intubation time. So if the patient transferred to the ICU without documented intubation time, will not be included in the study. And last point is if the patient stayed in the ICU for 24 hours or more, will not be included. Also, we don't include the readmitted patient.
Can you go back to just clarify the last one? I think the last one meant not to include second admission,
Yes.
readmission.
Yeah.
So the patient was admitted for the second time, and the first time was 24 hours or more. You don't include the second time.
Yeah.
So the readmissions, if the first admission was more than 24 hours, don't include the readmissions. If the patient was admitted very, very short time, first time, and second admission, then will be okay.
Yes. Okay. This is overview about screening in our site. We started on 13 November, Sunday this week. The total number of screened patients were 30 patients, so 30 new admitted patients in our participating ICUs. Out of 30 patients, 18 patients were enrolled, and the screening done by a research coordinator. And for data collection, we divide data collection between respiratory therapists and research coordinators. So the respiratory therapist will take part of respiratory and mechanical ventilation. And for research coordinator, will take the rest of data like baseline characteristics and clinical outcome. So that's all about inclusion and exclusion criteria and our screening.
So Amjad, if we can stop because there are 2 raised hands, maybe questions. So I have Dr. Ghalib first, and then Dr. Ayman, and then Ms. Lama. Dr. Ghalib, تفضل. Rose, can you unmute Dr. Ghalib?
Yes, Assalamu alaikum, everybody. That's really a very good initiative worldwide. But for the last point that in the exclusion criteria, those who are readmitted, even if the patient was enrolled in the previous admission.
Maybe Iman, do you have the protocol? Can you put the protocol on screen just to make sure we are getting this correct?
Yeah, sure. Actually, I have this as a note in my presentation about regarding the readmissions.
Yeah.
I'll share this.
What does it say? Just let's make sure we are getting it correct. If you can put the protocol, it will be helpful.
Okay.
I mean, if you are enroll the patient again, it will be duplication of the same patient.
Oh, for sure, we should not include the patient twice.
Yeah, that's my
but the patient in the first time, if he didn't meet the inclusion criteria, مريض دخل ساعتين ثلاثة على الاي سي يو, he did not meet the inclusion criteria and left and came back, and the second time he met. This is my understanding. Second time can be included.
Yeah, but providing that he was not enrolled in the
first time.
Admission.
Absolutely, yes. This is absolutely correct.
Okay, thank you. That's all.
Okay, Dr. Ayman. Rose, you need to help us, so we'll not unmute Dr. Ayman and then Dr. Ahmed Madi.
Can you see my screen?
No, I don't see it.
It disappeared.
Dr. Ayman, can you unmute yourself or no?
This is actually from the protocol I got regarding the readmission. The patient discharged from the hospital and subsequently readmitted will not be included as a new patient.
Yeah.
So even if the patient was transferred out of ICU and requires mechanical ventilation during the same hospital stay, will not be considered a new admission.
So this note says readmission will not be included at all.
Yes.
So it's different from what Amjad showed us. So I don't know. The other one says if less than 24 hours. Where's the source of that one, Amjad?
From vertical.
Just put the inclusion exclusion criteria.
This is the inclusion criteria for patients. You want the exclusion, right? The last one.
Mm-hmm.
Patients that were participating in ICU for 24 hours or more were readmitted during this ICU period. This will be excluded. They will be excluded. They're under exclusion criteria.
Patient were participating in ICU 24 hours or more.
And were readmitted during the study period, they will be excluded.
So it looks like they don't want readmissions at all.
Yes.
So that's easier.
Yeah.
Dr. Ayman. We have issue with unmuting. Rose. Okay, Rose will unmute Dr. Ayman and Dr. Ahmed for questions. Dr. Ayman, تفضل.
Assalamu alaikum, everybody, and thanks for this great initiative with the collaboration with Saudi Critical Care Trial Group. My question, you started collecting data. I went through the protocol actually before the meeting. You screened 30 and you included 12. Can we know you excluded of those 30, why you excluded the others? Were not ventilated or they are not meeting the exclusion criteria? What was the scenario? And second question I'm asking, because when I went to the protocol, they left consent for according to the center or the county site. Will we involve consent or will not do consenting for this case?
Good question. Amjad, can you respond to the why the patients 30 screened, some excluded? What are the reasons for exclusion?
Most of them are not intubated. For example, nasal cannula, but not high flow nasal cannula. So that's the main reason. Most of them not intubated.
So they are not intubated and not on high flow or non-invasive ventilation.
Yeah.
Yes.
Yeah.
So that's the main reason. How about the consent? Dr. Alia, maybe you want to comment on this one? The consent?
Yes. So the consent, at least in my opinion, the consented patients are the ones whom you will follow up after 6 months after discharge. Yes, yeah, Amjad?
Yes.
Yes. So when you call somebody after 6 months, you ask them, this is a part of research. Can I collect some questions? They respond, yes. This is verbal consent. It's like any survey. So if it is clarified in the proposal being submitted to the IRB, you will say we will collect data, we will not interfere, and however we will collect prospectively. I would suggest and advocate to ask for waiver of written consent and only limit a verbal consent once you collect the follow-up questions or questionnaire after discharge. However, I think it is variable from a center to center. We have a couple of centers here, including, I think, National Guard, where the IRB requested consenting.
Yes, indeed. So there are two parts of the study. One is the data collection prospective, doesn't have any intervention with patient. And if that's the only part, most IRBs or many IRBs would not request consent. But the part that require follow-up call to patient, this is where makes it a little harder. For our IRB requested that we get written consent, but not certainly before the follow-up. So we are taking written consents from patients. Amjad, what we are doing now?
For the consent?
Yeah.
We did not take any consent until now.
Yeah, but we are taking deferred consent, right?
Yeah, yeah.
We have to take consent. So
Yes.
before we call people, so you don't have to, because it's observational data, you don't have to do it necessarily day one. So if the family comes day 2 or 3, we have to take the consent. But certainly if we don't get consent, the patient data will be out. We need, at least for our site. For other sites, it depends on the IRB, what they tell you. If they request consent, you have to do it. Dr. Ahmed Madi.
Assalamu alaikum. Thank you, Dr. Racine. Thank you, everyone, for involving us in this very international and amazing study. Actually, I have three queries here. The first one about the non-invasive ventilation. It means whatever the settings of non-invasive, the high flow, the BiPAP, just more than 1 hour of any of them included. The first one. Second, also for the diagnosis, if you have the patient, for example, whatever the diagnosis or DNR or those, no matter the diagnosis of any patients, so any patient 12 hours or mechanical ventilated should be included. And about the consent, you open the point of the consent. If our center waived the consent, so it is the waiving for all the study, whatever the data collection or calling the family later on. So do I need to have a submit for the consent for follow-up later on for the long term or the second stage, or I will stick with my IRB, which is no consent? Thank you so much.
Dr. Madi, you have a no consent IRB?
I will check.
Waiver.
Yes, almost. I will check the details of that one, but I guess yes.
I agree. I think continue with it. Don't type it. It should be
Yes.
that way, actually.
Yes. Okay.
So if they give you approval,
I guess you don't have.
if the protocol you submitted says consent not required for the study and they approved it for you, so that's it, it's waived. But if they request consent, then you have to do consent. For the other part of the diagnoses, yes, this is looking at clinical practice of mechanical ventilation. So it is regardless of the diagnosis. In fact, one of the data elements is to see what's diagnosis. We're going to show this in a minute. So part of it is we're going to collect what's whether it's COPD or heart failure or whatever. So the causes or the indication for mechanical ventilation is part of the data. I don't know if that answers your question.
Okay, good. And the settings also of non-invasive, just 1 hour connected to non-invasive or high flow will be included.
Yeah,
Am I
that's
right?
correct. Yes, that's correct.
Okay, thank you so much.
Sounds good. Anything else, Amjad?
No, that's it.
Thank you very much. We have also Mr. Mohammed Lamtairi, who is the RT supervisor, who has been very, very helpful in collecting the respiratory data. So, Mohammed, do you want to make a comment from your side? Rose, can you make Mohammed unmuted?
Actually, Mohammed will share some part of the
Of your presentation?
yes, my
Okay,
presentation.
so sounds good. So we'll wait for him. So maybe next we'll move to Ms. Iman Qasim, going to present about prospective data collection. We have less than 20 minutes. So I think we're going to give the highlight of this. Details
Yes.
are all in the protocol. So تفضلي Ms. Iman.
We'll talk about prospective data collection, and I'll give some site updates on the status of the sites. We'll start with introduction. What do we mean by prospective data? And then data variables, what are they in brief? And then what's the timeline to start? So as Dr. Yassin has said, that it was extended until March 2023. So we'll talk about this in a minute. So what is prospective data collection? What's the difference between prospective data and retrospective? Prospective, we recruit the patient and we start the data collection while the patient is still in the ICU and still did not develop the outcome before any outcome of interest has been developed. And also there will be follow-up. So this is the difference between retrospective and prospective. So we'll not do the data retrospectively. We will do it prospectively while the patient is still in the ICU. So what's the main objectives of this study? To evaluate the clinical practice of mechanical ventilation in critically ill adult patients and the need of mechanical ventilation after COVID-19 pandemics. How did the practice change? And identify prospectively unsupervised clinical phenotypes that allow improving precision medicine. So part of this study, they want to do machine learning so that they will collect, this is why they want multiple centers to collect and multiple regions and countries to collect many data so that they can work on the artificial intelligence part of it for precision medicine. So the data variables, I think it's better showing it on the eCRF, electronic CRF. But I will start when should we collect the data. As my colleague Ms. Amjad said, regarding the inclusion, once the patient is admitted, new admission to ICU or has started on mechanical ventilation and this ICU, so this will be counted as day 0. and we will start enrolling the patient and collecting the data for this patient if the patient is on any ventilatory support, like high flow, non-invasive or invasive mechanical ventilation. For how long we will have set days, day 0, 1, and 2, and 7, 14, and 21. Until the outcome data will be at ICU discharge or death. And then there will be another data for follow-up, but all data will be recorded at 8 a.m. So even if the shift starts at 7, you will have to start data collection for this study protocol at 8 a.m. each day. What's the baseline data? We will collect demographic data, comorbidities, fertility scale, and I will show you. This is from the website. You have almost all of you saw this. Most of you have seen this because if they have access to the website. If you still don't have access to the website and you have an IRB approval, please let me know that we can get the access for your site so that you can start entering the data. So for your patient ID, you can start with serial number like 1, 2, 3, or it's totally up to you, but I wouldn't prefer to put any MRNs for not to breach confidentiality. And so if I will go to the website here, I'll show you the website.
Can I make a comment on this one, Ima? I think it's very important.
Yeah.
So if you put a number, you need to keep a log somewhere that this number corresponds to this MR number.
Yes, of course.
Otherwise, so if you have to go back and edit or fix some data or follow up, you know which patient is which. Otherwise, it will become a mess.
Yes.
So if you put a number 001 here, somewhere you need a key record. 001 is Mr. Flan, and his MR number is this one.
Yes. If you need a template on this one, I'm very happy to send a template on the enrollment log. I will share the website. So login, this is the login page. And this is one patient we've entered in the system just for this presentation to show. First, you will have an admission. Under admission, you will have to complete this data, this demographics, straightforward. After you complete the demographics and chest X-ray and the comorbidities that the patient has, you have to save the data. So this will pop up, will open, the other tabs will open accordingly after you finish completing this. Now, if you go to a new patient, add a new case, you will see only admission. After you finish completing the demographics, then you will have the other tabs. So first method is the first method of ventilatory support at ICU, which is either advanced any respiratory support or like high flow or, and these, don't worry about them. This is the forms that you will have to fill. They are listing. If this is what you will select, then you will have to fill this forms. If you will select the patient is started on mechanical ventilation at arrival in the ICU, then you will have to fill this forms. So this forms has opened after we select an invasive mechanical ventilation. So we'll see the forms, form A, mechanical ventilation A, and this is where you will need. This can be filled by the research coordinator or nursing staff, but you will need RT for sure to help with the data collection. If there is if you don't have an RT and you need help, Mr. Muhammad also may sit with the session with any of the team members that need help and explain all of the needed information. Then we'll have sessions for each one if this is needed. And then this is a ventilator setting, and ventilator setting, actually this is criteria used to select PEEP and all of this. Also RTs are very familiar with this information. If also you don't have an RT in your institution and you need help, this is Mr. Muhammad is gonna help in this, and it's straightforward. I think this pharmacological needs and then the sedation, nurses will be able to complete this, and actually it's just click yes or no if the patient is receiving any of these. So it's a straightforward thing. I don't think there is anything needs to be questioned. There is this one, this part actually needed help with the RTs. If Muhammad Ibn Tayri, can you explain this form?
Assalamu alaikum, I'm Muhammad Ibn Tayri, respiratory supervisor. We just started back few days, as we mentioned, collecting data. As you mentioned, Iman, it's straightforward data. As here, we have the complications of mechanical ventilation, like if we have barotrauma, or we have more than option we can select, like if we have VAP or intensive care unit acquired weakness, that's yes. We just put yes, no. We just put no. And you can, if you go down there, the ARDS risk factors. We have direct, like the pneumonia, aspiration pneumonia, the drowning, and if indirect, you can put the major trauma, anything there. If only choose one option is allowed.
Muhammad, that's my question. Can you go up to the top of the screen, scroll up? Risk factors, they accept only one or multiple?
For this slide, no, only one. As he said, if it's direct, we select only one option. One option is allowed.
When there, can you have direct and indirect, or no?
No.
So far, no. I didn't face. You know, we are still.
So that's important, because I mean, some patients could have more than one risk factor. So what basically they're asking us to select the most important one.
I think
right?
this is what they are meaning. Yes.
Yeah. So somebody is septic and aspirated. You have to make judgment which one is the most likely cause of his respiratory failure based on this clinical call here. Okay.
Agree.
Okay. I'll make this short so that we'll have time for Dr. Alia.
I think this is important, yeah, Iman, because many questions, and I think they will ask how will they do the days? Will they show it off? Will they do it in retrospect? So, and this is quite important.
I think this, yeah, okay. So then this is the complication during mechanical ventilation, and it's also selection.
So barotrauma, so for the coordinators who are on the call, I think we need to explain what barotrauma means. Do they have definition for barotrauma? So pneumothorax is a barotrauma. So here you have to look at X-rays and the doctor notes.
Yeah.
If there's pneumothorax, pneumomediastinum, subcutaneous emphysema, this is all called barotrauma. I think this is where you probably need to talk with the doctors about ventilator-associated pneumonia, ventilator-associated tracheobronchitis, sepsis syndrome.
And this is, you'll have to check all of these daily on these days.
On these days. It's not very difficult, but you need to have some understanding what these mean. And I think maybe ask one of the physicians will be very useful.
Yes, then the weaning form.
Before this, I think the point that mentioned by Dr. Ali about prospective, retrospective,
yeah,
So it is prospective data, but this is probably a common scenario. For example, tomorrow is a Thursday, okay?
Yes.
There will be patients who come tomorrow to the ICU. The coordinator may be able to start collecting data on these patients. But there are patients who are going to come on Friday, and it is possible in your unit there is no coordinator. Few patients who are going to come on Saturday, there's no coordinator. My suggestion that on Sunday you screen backwards, because we need to look at all admissions on consecutive days for a total of 28 days, right?
Yes.
For 28 days consecutive. For all admissions on these 28 days need to be screened and included. And that's okay. So on Sunday or Monday, I mean, even if some of these patients were identified retrospectively, I don't think it's a big deal. So we'll include them and collect data on them. I expect some of the data, I think we should try to collect the data on each day by each day, but if we lag behind a little bit, I don't think it's a necessarily a big deal. It's okay.
Yeah.
Does that address the point, Dr. Alia?
Yes. So because I agree with you, one time you will come on Sunday and you will fill day 5 and 6 retrospectively. So make sure that when you go on these days off, that the team would record these things. You don't want missing data as much as possible. The other thing is in the study protocol, there is 2 or 3 pages with definitions. Exactly what Dr. Yassin was saying, that you don't need to guess what these things mean, either in comorbidities, especially in the weaning. You might find a little bit some challenge in the weaning because they ask for some categories. They are defined there. Also for the frailty index and the functional status scoring. So they might not be here very clearly, but you will have them in the data dictionary in the protocol.
Yeah, can I ask Dr. Zuhair is with us if he has any comments? Dr. Zuhair has been keen and key really person in improving practice of mechanical ventilation. Rose, can you unmute Dr. Zuhair? I think I see him is on the call. Prof. Zuhair. And Dr. Zuhair is applying for IRB in multiple MOH hospitals. Rose, can you unmute Dr. Zuhair?
Yes, Prof. Who?
Dr. Zuhair Al-Asiri.
Okay.
Prof. Zuhair, I think you are unmuted now.
Where is he?
Yeah,
yes.
تفضل, yes.
Well, thank you very much for inviting me in this very nice and interesting study. So I would like to start by thanking you, Prof. Yassin, for having us in the study, especially Ministry of Health hospitals. And I would like to thank Alia as well for participating in leadership in this nice protocol. We are on board. We started already communicating the 8 hospitals that the man endorsed to us. Within a week or maximum 10 days, we'll start, inshallah, collecting data. It's very clear to me. I read the whole protocols. It's very straightforward, and I'm sure with the maximum, the next 2 weeks, we'll be able to provide you with good number of patients. And maybe my questions as well. We know that we have tele ICU, so we are at the same time seeing or observing monitoring 20 hospital as well. So if those could be included, we have no problem as well to add more centers if this is possible.
That will be fantastic. Dr. Ali, you want to make comment on the big picture? What are we trying to achieve? We want to
Yes.
include how many sites, how many patients,
Yes.
and maybe the
So-
publication policy, the authorship thing. So
Yes.
we'll just put this.
So because of the time, maybe I will not have enough time to present my couple of slides. But we thank you a lot, Dr. Zuhair, and I would be grateful if you would like me to look at the IRB application to try to tweak it to get away from the written consent. As we described that this is, and I think, to be honest with you, it is how you write the proposal that gets you away or involved or required to do a written consent. So if you would like my participation in that, I'm truly welcoming.
That's great. I think I will get the IRB. No worries about it.
Okay.
The question about the tele.
Yes,
hospital.
the tele ICU. So I know that the virtual ICU, the virtual hospital, has access to the radiology, to the ventilatory, and to the vital signs, and to the medical story or medical file. So this is all the data we need for the primary outcome. For the secondary outcome, which is...
Okay, so just let you know that the tele ICU covered, every single thing in the ICU. There is a consultant.
Yes.
It's led by consultants in the virtual hospital. And by the way, we got the price, alhamdulillah.
Yes, we saw that. That's very clear.
الحكومة الإلكترونية, our virtual hospital. So we could expand if needed. We could expand, the hospital and get involved in the study.
Sure. So the thing is, would be probably a little bit challenging. Can you get a phone number of the relatives of the patient that you added to the number of the serial number of the patient that we log, that we can follow them after 6 months to see their outcomes? Is that feasible?
Definitely. It's a real, it's almost like a physical ICU. It's
Physical ICU, perfect.
Yeah,
Then I think involving and including the tele ICU would hit 2 objectives. Number one, it would increase the sample, and that would be a major outcome that we are looking for, because giving the population number in Saudi Arabia, we need to include more than 1,000 patients, so or 900 to 1,000 patients, and that would help us. And the other objective, I think it will add to the success of the tele ICU, because this would be probably one of the first studies that if we are able to include large number through the tele ICU, I would believe this would hit as one of the success of tele ICU in the form of providing a platform for contribution of multi-center study, that eventually, when we do our local research on this data, you can definitely use it to study the variation and the description of practice and behavior of therapy in the ICU, and definitely can, after that, lead improvement projects out of it. So actually, I think it's extremely amazing if we could include them.
I think it's a major opportunity, honestly. I think it's a great, great opportunity. And I know you have a few, I think if we can stick for a few minutes to show you the site status and maybe the slides that you prepared, Ali, about some study ideas. And I think the electronic ICU is really a good one if we manage to get a good number of patients. So if we get number of good ICUs managed by eICU and good number of patients there, then you can compare the practices for eICU versus non-eICU, and the outcome between them, it will be really unique and novel. So so you mentioned we want around 1,000 patients. I think with the number of sites we have and the great people who have on the call today, we will be able to achieve this. this part of a global study. So the agreement with the guys, the global guys, the main study gonna happen and have nothing to do with it. We're gonna do it, but they agreed that the data from Saudi Arabia will be available for us, and the authorship, Ali gonna be leading on this one, and the people from the sites will be on the studies that come from Saudi Arabia, the Saudi Arabia data set, right, Talia? This is a plan. Dr. Alia? There are a couple of hands raised, but I'm gonna just go over the site stuff if you allow me, and then we'll come to your questions, if that's okay. Just let's, the discussion has been fantastic. So Iman, you wanna tell us about the sites status?
Yeah, sure. We have 27 sites interested, and 2 have started. I think 3 have started since Dr. Ayman from King Fahd Hospital in Medina also started data collection. 3 have started, and we have 11 ready to start. They have the IRB approval. So hopefully next Sunday they can start. This is all what I have for the site.
So how many started already?
Started 3.
So 3, fantastic. So many are IRBs in process. I think we'll be able to get the 1,000 patient hopefully easily with the effort, but we really need a good number. What's a minimum number we need from each site, Dr. Alia, that we said to meet authorship criteria? Alia, I don't know.
Yeah, the minimum we need is 40. And we could increase the number of authorship. We can number of authorship if we could duplicate this number.
Yes. One thing about the study, we need the 180-day outcome, which means a phone call at day 180. So we need to make sure that we keep mobile number or contact of the people. So we have a few hand raised. I think we finished the presentation. So maybe if